Mm.
So HCPCS stands for Healthcare Common Procedure Coding System. And this is what we refer to as level two. So your CPT book, last week I did have a question from somebody that said, well, what's level one? So this kind of brings in the contrast visually for you to see that your CPT book is HCPCS level one, and then HCPCS level two is this additional book. The difference in the books, because they're both published by the American Medical Association, but the difference in the book is your CPT level one HCPCS is for services and procedures, and the level two is for drugs, supplies, and equipment. What they call equipment or products. So a product could be anything down to those bed liners that they would put under someone if they're in the hospital, to a maxi pad, to a walker or crutches or a CPAP machine. That would be all considered product, supplies, and services. And also drugs are included in that. Like the charge for the actual medication is also a part of HCPCS level two. So if you open the book, the first is going to look a lot similar to your CPT book, because as soon as you open on that first inside cover, you have your CPT modifiers, which they're the same because these are all HCPCS modifiers that can be used for level one or level two, because these are all published by, again, the American Medical Association, so same entity. Um, So same modifiers on the inside cover. Now there are some HCPCS level two modifiers that are only used for level two services, like, and you won't be able to tell what they are because they're related to product supplies or drugs. Like if you're looking on the inside cover right now under the HCPCS modifiers, they have like modifiers for dressing a wound. They have modifiers for a registered dietitian, so you can kind of see that those are specific to HCPCS level two. We'll see examples of how to use those later. You also see that there's tabs with this book as well on the inside cover. So and I'm only going to give you a few things to tab, and then I think from here y'all will probably be able to figure it out. But one thing I want you to tab is the page three. There is the introduction page, and there's a tab in the at the very top of that tab list that says intro, and that should go on page three of this book.
Do we put it at? Do you want us to put it at the top?
This one, yeah, put it at the top.
Okay.
Because what that introduction page does is um, it tells you what HCPCS level two is, and what all it includes as far as features in the book. But the main thing that you would need to know is what the acronym of HCPCS or HCPCS stands for, and it's the Healthcare Common Procedure Coding System. Do you need to memorize it? No, because it's in the book, so you'll have this book during your exam. The only thing that you'll need to do is just reference that introduction page, and you'll have the answer to what does HCPCS stand for. So if you also turn to the next page, page four, there's a tab for symbols and conventions. So just like in our ICD-10 book, as well as our y'all might be hearing me turning pages and not necessarily static. I saw a message come through, but everybody can if everybody can mute, it could be that somebody maybe has a microphone close by, and they're breathing in it. It's possible. Or maybe your microphone is like rubbing up against your clothes or something. Um,
Can you mute me? I can't find my mute thing. I'm not
Yes.
sure. Can you just mute me,
Okay.
please? Thank
Yes,
you.
ma'am. You're officially muted. And looks like everybody else is. Or maybe not. Hold on, let me see.
I'm muted.
Oh, mute. Okay. So I just muted everybody. So if y'all have a question, unmute or drop it in the chat box, which I'll move over here so I can see it. Okay. Yep, the tab on page 4, symbols and conventions. So there's a tab for that. And y'all can put that on, well, you have to put it on page 5 for it to show up, for you to see it, since page 4 is on the left-hand side. And then there's another tab for instructions, which you could also put on at the top of page 5. And so you're putting these at the top so they can be kind of like a quick find for you. All right. Next tab or next page. Sorry. So on the on pages 4 and 5. So on page 4, you have symbols and conventions. So remember, we had conventions in the ICD-10 CM coding book. Conventions are those rules that will apply throughout the entire book. And the symbols you will also see throughout the entire book. Guidelines are specific and could be specific to a particular section or set of codes. But again, conventions apply to all. Next on page 5, you have instructions for using this book, and this is also another common thing that you have seen in the other 2 coding books as well. So it's not anything particularly that stands out. Really, you use all of the coding books the same, as far as, but the difference is probably going to be the layout of the book. So, like we saw with ICD 10 CM, the big one, guidelines in the front, index to diseases in the middle, tabular list in the back. But with the CPT book, you have illustrations in the front. Then you had your CPT code sections by page in a numeric order by the code. And then in the back of the book was your index. So this one is slightly different. So turn to page, well, hold on. If you look at pages 12, page 12 starts a section that is titled New, Revised, and Deleted Codes for 2022. Not all of your code books will have this, but this one does have it. And so anything that was any code that's new, um, where they may have revised it or maybe changed the description, or if it was a deleted code, they're just listing that in this area. That's beneficial because what if um, what if we build out some claims to United Healthcare on December 31st? And they say, well, this was not an active claim. Well, at least we can look in this book and say, or they say something was wrong with the coding. Then we can reference back to this book and say, nope, on December 31st of 2021, this was an active code and it wasn't deleted until January 1st, 2022. So then we kind of have our own reference in the book to justify our billing and why we should get paid for that service on that claim. Page 25 in this book. For those of you who have been stressing about anatomy and medical terminology, how will I know what this is? How will I memorize that? I echo again, you do not have to memorize anything in regards to anatomy or terminology. It would be helpful to you if you did, but you also have all of these great references, like you had the section in the tabular list of ICD-10, where you can reference anatomy, terminology, and the functions of those organs. Well, in this book, you have anatomical illustrations, anatomy, diagrams of all of the same things, the organ systems. What I have found with the books, though, is that every book has a different diagram. Like this first one on page 25 is of the circulatory system, arteries, and veins. Now there's a diagram of the circulatory system in the ICD-10-CM book, but it's not as big as this one. And then there's one in the CPT book, but it's not as detailed as this one. So, reference all of your books and check all of your books so that you'll be able to find your answers. What I also like about some of the ones that's in this book, if you look on page 27, so on page 27, that's up at the top, that illustration, electrical conducting system of the heart. So it actually gives you some additional details in those rectangular boxes right there, that tells you about how blood flows through the heart. So this is all about, this is actually a good illustration of how your blood pressure is measured, systolic and diastolic. Um, so just to kind of point that out. So these illustrations go from page 25 to page 60. So that in itself should make you excited to know that if you get stuck on an anatomy question, you got several places that you can go to try to find your answer. So really, you should not get stuck on an anatomy thing. It just be for you. It would just be a matter of saying, "Oh, let me get my HCPCS level 2 book. Let me pick that one up because I know it has the best pictures." Or let me go to my ICD-10-CM book because I know it has a list of the organs that's included in that organ system. Or let me pick up the CPT because it has a picture of the procedure, in that book. Um, and there should be a tab for that as well. Like not all of them, but uh, anatomic illustrations, there is a tab for that. So you can put that tab on page 25. And I would also put that one at the top somewhere. All right. So here we get to the meat of after page 60. Once you start on page 61. So remember your index to diseases looks similar, right? Page 61, except this is your index to services, supplies, equipment, and drugs. So if you're looking for, and it's alphabetized, just like all of your other indexes. So if you are looking for, let's see, if we are looking for a code for crutches, right? Patient comes in, got a broken leg or whatever. They go to the emergency room. They can say, here's some crutches until you can get set up with an orthopedic um, doctor. So they order the crutch. They give the patient the crutches, but they have to bill for that they give. So if you find crutches, I'm not even gonna tell you the page, but if y'all find crutches in that alphabetic index, and I'll give y'all a couple of minutes to find it. Everybody find crutches? I'll give you a hint. It is on page 71. All right, so on page 71, if you're looking in that first column, you should see crutches. And crutches, they have a few couple of options. So your coding concepts still remain the same. You're still going to code to the highest level of specificity, right? So let's say the patient was given forearm crutches, the ones that go around your wrist. If they were given forearm crutches, if they were given one, like just one for the left on the left side, then we would use the code E0111, um, which if you look at the slide, anything that starts with the letter E corresponds to durable medical equipment. But that would be because the description in the book says forearm crutches for each. We would only use that if the patient was given a left or a right. Now, if they were given both crutches, a pair of forearm crutches, the ones that go around your wrist, then we would use the code E0110. Any questions on that concept? So let's look at, go down a little bit further and look at the crutches for the underarm. So we've seen the forearm crutches. The underarm crutches are standard. They would either be wood crutches or metal, right? Metal or plastic, whatever they are. They could be rubber, but I think they're metal. So the wood crutches, if you look at, well, actually, let me just start with underarm articulating. So the articulating ones are the ones that you can adjust um, the height by. Again, you see if it was just one crutch, then you would use E0116. But if it was a pair of underarm articulating crutches, then you would use E0114. I feel like they should just delete this code for wood crutches because who's giving out wood crutches anymore? What are we, Tiny Tim? um, but if, again, you see the same concept of coding for the wood crutches. Let's look at another type of, well, just look just above, actually. Look just above crutches and you see CPAP. So some of us probably know what a CPAP machine is because we have to sleep with one. But it's a continuous positive pressurized airway pressure, where they're pushing pressurized air for people who have obstructive sleep apnea. So if you have obstructive sleep apnea, that means something is obstructing your airway, right? So they have to open your airway up in order to push air through. So for the device of the CPAP, you see one code, E0601. For the headgear of the CPAP, there's A7035. And then for the humidifier, there's A7046. Now, nowadays, the CPAP machine has a built-in humidifier, so it's likely you probably wouldn't need both codes, but you never know. So they haven't deleted the codes, so obviously they still have CPAP machines that don't have a humidifier built into it. Um, any questions and just kind of looking at those few examples. So yes, this is the index to services, supplies, equipments, and drugs, and this goes up to page 100. So this would be your starting point. If you were coming to this book to code something um, that was not a drug, if you were coming to code something that was not a drug, you would use this index to services, supplies, equipments. Now, the next sections that they have in this book is very, very similar to your tabular list. So it has, it's broken down by the type of um, service, equipment, or supply is being coded. And this is where we kind of break this down. So those of us who may work in healthcare may be just familiar with saying J codes because we know J codes are the only codes that are used for drugs and chemotherapy. Um, or we may be used to saying E codes because E codes are the only codes used for durable medical equipment. Um, so it's good to know this information, but honestly, again, this section is kind of like your tabular list. So like if we look at the what was the E0116, just because that's one I memorized off the top of my head. E0. Yep. If you go to E0116 in that tabular section, then it gives you the full description of that code, which is a crutch underarm other than wood, adjustable or fixed. So that's good to confirm just in case you wasn't sure that articulating crutches meant that they could be adjusted. So this is what confirms that description for you. So you kind of use it just like you would use the ICD-10-CM book. You go to the index, you find your code, then you go to this tabular to confirm your code is correct based on the description. Um, so yeah, E0116, crutch underarm other than wood, adjustable or fixed, with pad, tip, hand grip, with or without shock absorber. Questions? Okay. Um, So once we get done with this, we're gonna do some examples. I just want to make sure everybody kind of fully understands chapter 6 as your introduction to CPT because that's all we're going to be doing for like the next 10 weeks. All right. Let's go to another big section of this book, major section of this book, which is the it'll be on page 429. This is probably the biggest reason you would ever come to this book, quite honestly. So, the way the CPC exam is broken up down, um, there's only going to be like 5 questions that come from this book. Guarantee you those 5 questions are only going to be related to drugs or modifiers. So I'll show you another area where there's modifiers in this book. So page 429, and if you're looking for a tab, it is there's not one, but there's several blank tabs. There is a tab for your index and tabular list though. So take one of those blank ones and put wherever you would like so that you'll know that this is page 429 for your table of drugs and chemicals. Um, And let me get to the slide that references that, because honestly, that is going to be the most important. Okay. So the table of drugs and chemicals on page 429 of this book is alphabetized by the drug name, and it has columns in the table that indicate the name of the drug, the dosage, the delivery method, and the code. Depending on the type of practice or specialty you're going to be working in, the use of the level 2 codes may be limited to only a few sections. So one section with frequent use is the J codes. As I said, this is probably the most important part of HCPCS level 2 because every doctor's office uses or administers drugs or vaccinations at some point. So just taking a look at page 429, I want to kind of start at the top so that you can see that there's a grid of or a list of what the abbreviations stand for. And these again are the delivery methods of which of how the drugs can be entered into the body. So IA, and y'all can highlight these, please. IA is intra-arterial administration. So a drug can enter the body being directed or infused directly into an artery. It could also be via IV, which is probably the most popular or the quickest way for it to enter the system and affect your system. IV, which is intravenous. IM is intramuscular. So intramuscular is how they give vaccinations, flu shots. They have to give it in your. Typically, they'll use your deltoid muscle in your arm. IT is intrathecal, and this is actually uh, spinal injection, intrathecal. So, like if they're doing thinking, if they do, oh, if they do a circumcision on babies, that's one example. But also, um, why can't I think of what is it that they give when you're having a baby and they give you the oh hold on, let me unmute you. I hear you, I see you. What is it?
Oh, I think she answered it. I don't know. Were you talking about epidural?
Yes.
Okay.
I could not think of the word. Okay. Epidural, thank you. So yes, those are given intrathecally. Subcutaneous would be like your TB test, where it just goes just below the cutaneous level of the skin. INH is through inhalation, like your nebulizers, medications. You have to inhale those. VAR is various routes. So if the medication was given via various routes, like I've had a steroid injection and I've also had an oral steroid at the same time. Um, OTH stands for other, and then oral is by mouth. So typically, if you see IM, so they did make a change that I recognize just right off the bat looking at this, is there used to be an abbreviation for injection, but I see they've changed it and they just put IM for intramuscular, um, which makes sense to me and probably anybody else who works in healthcare because in order for you to get through to the muscle, you have to inject it. There's no other way to get there. Um, so it's going to be good for you to know those because that is going to be the key thing in selecting your proper J code for the medication. So let's look at some examples. Well, hold on. Let's talk about this first. So y'all ever see where they have medication that they have to take out of they have to suction out of the vial in order to give it to you. Like if you're getting a shot and they have to take it out of the vial. They're not supposed to. Well, let me just look at this real quick, because I think I know it by heart, it might be something different because they changed so much. But yeah, it used to be that you could puncture a vial to medicate a patient, and then you store that vial, put it in the refrigerator, that little bottle of meds, and then you could just use it on the next patient. Well, they have frowned upon that because once you puncture it, it's no longer sterile, right? When you puncture it, it's getting bacteria or whatever is in the air. So it's like reusing a needle, you can't reuse it. Um, so single-use vials of drugs may contain more medication than is administered to the patient. But when a provider administers only a portion of the vial to the patient, and must discard the remaining medication according to CMS guidelines, the provider may bill for the remaining portion of the medication discarded if the amount is over the billing unit reported by the HCPCS code. In other words, they have to discard of or throw away the vial, but they can still bill for it, an entire jar. So that their medication is not being wasted and they're still getting reimbursed for what wasn't used, because it can't be used legally, if that makes sense. So when that happens, the claim should be reported with one line item indicating the amount of the drug used, and a second line item should be reported with the amount of the drug that was thrown away or discarded with modifier JW, which JW means amount discarded and not administered to any patient. So this would be good for you to kind of write down and make note of. So like say for example, that's a good example too. So the patient was given a medication that came in a jar or a vial. Matter of fact, do I have my where is my I don't have vials of medication here, but I did have something that I could use as an example. A Flonase, but I can't find it now. I'm gonna need that by tomorrow morning. But anyways, I'll find it by then, hopefully. But I was just gonna use that as a visual. So 1 milligram vial, and the patient was only given half of that. They were given 0.5 milligrams. So, um, that means they only used half of what was in the jar, so they can bill that the patient was given 0.5 milligrams, but they also have to bill the 0.5 that was not used on the patient. They just have to add this modifier to the code so that the insurance company knows that, hey, this is how much we had to throw away, so we still hope to get some type of payment, on this. So this talks about finding a code. So let's use this example that is on the slide of Lanoxin. It's Lanoxin, just in case you can't see it. And so let's look in this table. So this table of drugs and chemicals or biologicals, it used to be called chemicals, but now it's called biologicals. But again, alphabetized. So if we're looking for the drug Lanoxin, Lanoxin, let's find that in the table. Lanoxin. And if you need help finding it, it's on page 439. So looking at Lanoxin, and we can explore the table a little bit too. So we see the table, the drug name is the first column. The unit per which the drug is given is in the second column. The route of administration of that drug is in the third column, and then the code for that drug is in the fourth column. Everybody see that so far? So looking at this under the unit per column for Lanoxin, it says that it is given in units up to 0.5 milligrams. Also under the route, it says that it can be given intravenously or intramuscular, which intramuscular means injection. And then it says that the code is J1160. So let's say if the patient was given 1 unit, look at me. If the patient was given 1 milligram of Lanoxin, we would need to report the code as such, and it would be J1160 times 2, because the J1160 only represents 0.5 milligrams if you report it one time. But if the patient was given 1 full milligram, we have to report it twice in order for us to get billed for the full amount or full dosage that the patient was given. So these codes is okay to report multiples. So consider also that you're going to be answering most of your questions, all of your questions in the exam format in multiple choice. So if they give you a question that says, how should this be reported? And they say J, well, they won't confuse you like that, but it should be J1160 times 2. And that's how you see it. If we want to look at another example, let's look at a drug that's probably more common. Let's see. Look for oh my gosh, yeah. I just freaked out because I was just thinking like, oh my God, I forgot to pick up my niece from daycare. They would have called by now. Her mom picked her up today. um, so let's look at aspirin. And I don't see it. Aspirin. Aspirin. I'm spelling it right. Because, hold on. Oh, nope, that's Tylenol. Okay, let's not look for aspirin. Let's instead look for trying to find a good example. Okay, let's instead look for albuterol. Albuterol. Oh, I'm so sorry, Shields. I'm just seeing your question. I will address that in just a moment. So if you look on page 429 and you see albuterol, there are 1, 2, 3, 4, 5 options for albuterol. And that is because albuterol comes in different forms. It is in a concentrated form, compounded. It is in, and these would be, well, hold on. Let me keep that to myself for a sec. It is in a concentrated form, non-compounded. Then there's albuterol unit dose, compounded, and albuterol unit dose, non-compounded. And I feel like I missed one. Oh, albuterol and ipratropium bromide, non-compounded. So that would be the dual neb. Two medications is a dual. So that albuterol and ipratropium is dual neb. So you can see that that particular one has two different medications in it. It has up to 2.5 milligrams of albuterol and then zero point 0.5 milligrams of the second medication. Um, and so what we would need to know from the doctor, from the um, clinician, whether it be a doctor, nurse practitioner, or PA who's ordering the medication, which form of albuterol was given or administered. So that's one of those ones where you kind of have to put your coding hat on as far as decision making process. Wanted y'all to see that example, and then um, Botox. Go to Botox for me. Botox. So Botox on page 431. You see that there's two types, right? There's a Botox cosmetic, and then there's a Botox, just Botox, regular old Botox. So obviously the cosmetic would be identified based on um, the diagnosis of the patient, right? Like if somebody was being given albuterol, then we would have to know that their diagnosis would likely be asthma or bronchitis or COPD or something along those lines that's dealing with a respiratory condition. If someone was being given cosmetic Botox, then their diagnosis would be something along the lines of um, maybe cellulitis, because baggy skin is nothing but cellulitis, or cellulite. Um, Maybe drooping eyes. That's not the proper term. I just can't think of it. But their diagnosis may be drooping eyes. But whatever the case, you would know that it is related to something cosmetic, right? And that's how you would be able to decipher whether they're getting cosmetic Botox or the other form of Botox, which is typically used um, for promoting faster healing in the body. Botox kind of acts very similar to steroids, where it's like an anti-inflammatory. So they'll do Botox injections in patients that have GI issues, like esophageal, like if they have maybe their esophagus is not contracting properly for the food to go down when you swallow. So they'll give Botox injections for that. They'll give Botox injections in the intestines, specifically if the intestines, like somebody maybe have constipation or a severe form where they need the enhancement of Botox to help that particular organ or area be able to function better. So two different type of Botoxes, and your diagnosis is always going to be like your key indicator to help you be able to decipher what medication is being administered when you have to make a decision as we saw with Botox, with albuterol, and the other examples that we've looked at. Questions? Everybody good? Okay. Um, Finding a code, another example. Let's go for orthopedic shoes. When I think orthopedic shoes, it reminds me of when I used to work at Belk back in my, I'll say shortly after high school years, before I started selling life insurance. But I worked at Belk, and like Easy Spirits was like the hot thing on the street for anybody over 70. For anybody over 70. All those ladies came in there for Easy Spirits. And if there was an Easy Spirit sale, because they were like a high end shoe, so they never did sales. You know, those premium brands, they don't do sales or coupons or things like that. They're always excluded. So yeah, when Easy Spirit, the manufacturer offered 20% off, we got an onslaught of 70 plus. So yeah, that's orthopedic shoes, but they weren't even that comfortable. I bought a pair. They were like $80 shoes. I would never in this lifetime ever again buy a pair of Easy Spirits. I don't care if they make Easy Spirit high top sneakers. I'm not wearing them. So orthopedic shoes. If somebody finds the page before the rest of us does. Oh, look, that is so funny because I didn't even realize the description said high top. Still not wearing them. L3204. So they gave us the code that we could go to for the tabular, but I still want to look for it in the index so everybody has the concept. Orthopedic shoes. They got more, certainly have more orthopedic shoe options than I was thinking that there were. Um, so let's just roll with the slide and what's on the slide, L3204, and go to the tabular section. So the tabs that you have in the front, you see how the tabs have A, B, C, D, E, F, G. Those go to the tabular section of this book. So you can put those in at your leisure, and they'll go on the side edge. The description for L3204 reads, excuse me. All right. Orthopedic shoes. So same thing on the slide. High top with supinator or pronator for an infant. So these are infant shoes. If you look at the code just above that, it says the L3203, that shoe is for a junior. So it's an Oxford with supinator or pronator for a junior. If you look at L3202, that would be for a child, and then 3201 for infant. So now that I'm looking at these, I'm probably asking the same question y'all are asking. How are they differing between an infant, a child, a junior, and a junior? Because in my mind, they all the same, but they have different codes. So that must mean that there's a specific age cutoff. for these. So what I will tell you is, again, on the exam, with these, likely your questions are either going to be related to modifiers or drugs. I would not imagine them asking you anything else from this book, with the exception of one other question, and that would be related to the payment system. So I'll save that for last, but let's now, so any questions on the index, the table of drugs, or the tabular list from this book? Probably seeing it is because you've seen the other books now, is probably getting a little bit more familiar with you, but you may have questions once you sit down and actually try to go back and do the exercises again, now that you've had a formal introduction to the book. So y'all please let me know. See? And then the other thing I wanted to show y'all, so back cover of this book, the very back cover. Not the inside of it, but the one where you have the anesthesia modifiers and the ambulatory modifiers. Those the anesthesia modifiers are only used for anesthesia codes, and those are going to be introduced to y'all probably around chapter 16, 17 when we do anesthesia services. But just know that these modifiers are in this book, their description, and then the ambulatory modifiers are also in the HCPCS level 1/CPT book. Other modifiers that are here probably will not mean a hill of beans to y'all, because they're not going to test you on it. Those 5 questions won't be very, very detailed. They will just be hitting the surface of, do you know what HCPCS is? Do you know the purpose of it? This book also has several appendixes or appendices, like the CPT book does. Let's see. And then the last thing from this book is going to be and pardon me going backwards through the slides because it's back here and I need to find it. Oops, was that it? Nope. I think that's it. No, C codes. I do need to hit that real quick. The only thing I need to hit about C codes is the fact that because they mentioned the outpatient prospective payment system. So what you need to know about that, and I would maybe just jot this down somewhere, that the outpatient prospective payment system is the payment system that is utilized for outpatient services. So this is what this is the payment system that's used by hospitals in order to get paid for their services, for their technical services. So remember we kind of talked about how, a doctor works inside the hospital, which means he works for the hospital, but he may have his own practice as well. So think about like those internal medicinists, right? They have their own internal medicine practice, but they admit patients to the hospital. So if their patients are admitted to the hospital, they still go to the hospital to do rounds on their patients, right? So they have to get paid not only for the services that they provide in their practice, which would be the evaluation and management office services, but they also get paid for the services that they provide to the patient while they're in the hospital. That's paid to them from the hospital. So they get two checks, essentially. One is going to be more than the other. The hospital check is probably going to be more than the other. Because for an office visit, they likely are only billing. You go see a doctor for like 15 minutes, return visit patient, a return patient. That visit is probably only $120. So they're probably only going to get paid like 30 of that 120 because if their insurance company is in network, if they're in network, then they get a discount. The patient gets a discount, not the doctor. So doctor is probably only going to get paid pennies off of that 120 in the end if you count like his expenses for malpractice insurance and all of that stuff. So what they get paid from the hospital is kind of like their bread and butter. And that is paid to them through the outpatient prospective payment system. Um, it is for hospital outpatient departments and ambulatory surgical centers. So even though it says outpatient, observation is considered outpatient. You ever been admitted? Well, it is contradicting in a sense because you're saying admitted to outpatient, but you didn't spend. In order to be considered to inpatient, you have to spend 2 midnights. So like if I went in right now and they said, "Oh, we're gonna keep you for observation," and they keep me from what 8 o'clock tonight to uh 11 o'clock tomorrow morning, that's not 24 hours, right? So that wouldn't be considered inpatient. It would be considered outpatient, but just under observation, which the doctor still would have to come into the hospital to do his rounds on me to see me. So that's how he would get paid for that service. Same thing with an ambulatory surgical center. Most hospitals have ambulatory surgery centers where they're doing outpatient surgeries. They even do, they try to do the most complex things on an outpatient basis. Um, like mastectomies, like knee replacements. Like you can't just send somebody home after they had a knee replacement. Are you kidding me? Right, my Kathy? Like you at least need one night. um, but yeah, that that is all considered outpatient. And so what Medicare, the CMS, Center for Medicare and Medicaid Services, they put out a list every year of procedures that they consider inpatient only and that they consider outpatient only. And all of it doesn't make any sense, but this is how it works. So let's just say a knee replacement surgery, right? Total knee replacement is on the list to be inpatient only, but they don't admit patients for those, right? So that means if a doctor does this surgery outpatient, as the hospital has told him to do, even though CMS said it should be inpatient, and he does it as outpatient, he bills for it, CMS is not going to pay for it. They're not going to pay for it. They're not going to pay the 80%. Usually, those patients have Medicare. Patient pays 20, CMS pays 80. They don't pay anything. So the only thing that the doctor is getting if the patient pays the 20% is the 20%. Sucks, right? So yeah, salute to our doctors because they work hard and they don't really get paid that much, and they got a lot of student loan debt. It's hard for them, hard for us, so we know it's hard for them. All right. So yeah, that is going back through these slides so I can get through. That's HCPCS level 2. So now you've had a good introduction to both HCPCS level 2 and level 1. We got to talk about surgeries. So that's the other major part of this presentation. So this last, where are we? This last 45 minutes will give us a good run getting through the surgery section. And then I hope to be able to do a few examples that'll be beneficial to helping y'all with the homework. So, oh, CPT Global Package. Turn in your CPT book back to the CPT book, and we're going to go to page. We're going to go to page. That's anesthesia. Let's go to page. Hold on. Oh, okay. 88. Page 88. I agree with you, Shields. Shields says another reason this country is in a jam. I 100% agree with you. It gets me that the same people who determines whether or not they're going to pay is also the people that pick the prices for what it's going to be and the reimbursement. It's just not fair. Surgery guidelines, page 88, 89, and 90. So in this section, I want y'all to think about yourself. Think about when you have had surgery. Think about you go to the doctor, and let's just stick with the total knee replacement since I've used that already. You go to your orthopedist or orthopedic specialist, and they say, hey, your knee's messed up. Gonna have to give you a new one. Um, so in that visit, you go for that office visit, and in that visit, they make a decision that yes, you need to have surgery. They ask you, do you consent? You say yes, and they move forward with scheduling your surgical procedure, right? So in every so this is where the global surgical package comes into play. It has a timestamp. It's from that moment that the decision for you to have surgery was made until the moment where the surgeon releases you from their care. It's typically a 6 week type period, right? Um, six weeks or more type period. Um, actually, well, we'll talk about that. Um, but knowing your surgical guidelines and a payer's definition of the surgical global package is going to help you with correct CPT coding. Payments for surgical procedures include the standard package of preoperative, so anything that happens from the time that the decision is made until you actually have the surgery, pre-operative, and then there's your intraoperative period. That's the things that are happening during your surgery. And then the post-operative is things that happen after your surgery until your release date from the care of that physician. Um, so it talks about payer policies, and that's because you have your government payers like your Medicare, your TRICARE, your um, Medicaid. Those are your government payers. And then you have your commercial payers like your Blue Cross Blue Shield, your United Healthcare, Humana, which could be, a commercial intertwined with a government plan. like Medicare, what they call it, a managed care. Sorry. But in your CPT code book, you will find a list of services that are included in the global surgical package. Beginning on page 88, that's the CPT surgical package definition. Because these services are included to the surgery, they are not separately billable. The list can be found again on page 88. So the things that are inclusive or included in the surgery package and not separately billable are your local infiltration for metacarpal or metatarsal digital block or topical anesthesia. So if you were having, for example, um, well, no, that would be different. So local infiltration would be if they're about to give you an IV, right? They got to numb you in order to do that. So that's an example of that. Evaluation and management services subsequent to the decision for surgery on the day before and or day of surgery, including history and physicals. So you know how the nurse will call you before you have surgery and do an examination, or they'll either interview you or do an examination, like what meds are you currently taking, what's the underlying conditions do you have, are you allergic to anything? Um, they'll go through, those steps, and that is a part of your pre-op, or your history and physical. And then before the anesthesia is administered, usually the anesthesiologist or someone will come in from their team to check your blood pressure. Um, they'll examine you. They look at your teeth, too. They make sure that you can handle being intubated, that they'll be able to intubate you with no issues to keep you breathing. Um, and, checking your blood pressure, just make sure that you're able to withhold the amount of strain that's going to be on your body while you're um, under for the surgery. So that's part of the global package as well. They don't charge you extra for that. That's all included in the surgery price. Also, what's included is immediate post-operative care, like when you go to the PACU for recovery. That includes dictating operative notes, talking with the family and other physicians or other qualified healthcare professionals, writing orders. So if they have to, before they do your discharge, they write up any medication prescriptions you're going to need for post-op pain. Evaluating the patient in the post-anesthesia recovery area. This is where they finally wake you up. Um, and then typical post-operative follow-up care. This would be your, visits after your surgery, maybe a week later, maybe 2 weeks later, 3 weeks, until they finally discharge you. So that's your surgery global package, all inclusive. So there's a difference in any questions on the global package. So you can find that on page 88. Once again, and I do ask, like I said, for y'all to kind of put yourself in the situation, or maybe a family member, if you can think back to the last time when someone has had surgery, and how that scenario goes. Like, this is probably a refresher, or just kind of bringing some of those things to light as far as the timeline in which they happen as well. Major surgery versus minor surgery. So major surgery has a preoperative period of 1 day with 90 days for the post-op. That means um, total knee replacement. You had your preoperative period of 1 day before the surgery, usually when, again, the nurses is calling you to get you prepped and give you instructions for your procedure. And then 90 days, so, up to 3 months. For some people, it doesn't take that long, but doctors know that the 90 days is a part of your package, so they're going to use it because they've billed for it. And, ethically, by law, they should treat you until you're fully recovered. Minor surgery. So minor surgery, perfect example for this is when I had my carpal tunnel release on my right hand, and I had that procedure, And the doctor was like, "Oh, you can go back to work after 2 days." And I was like, "The hell? No, I will not." I'm not going back to work after 2 days from having surgery. I don't care how minor you think it was. It hurts, right? So, for a procedure that they consider a minor procedure, it could be something as minute as an injection, maybe a cortisone injection, or maybe even minor procedures or minor surgery is an injection. It could be a flu shot. An epidural is considered a minor surgery as well. But in anything time something penetrates your body, that's a procedure or minor, because not the grace period, the global package for that is 0 to 10 days. So essentially, with my carpal tunnel release, the total recovery time for that, 10 days, that the doctor would see me and release me for that. Um, any questions on major versus minor? So anything major would take up to 90 days for recovery. Anything minor, 10 days or less. So this just kind of goes over, I'll hit on this really quick. This is the physicians' fee services, kind of like their payment system. So each surgery has what they call a RVU, or a relative value unit assigned to it. And that just, again, goes in line with payment. So the higher the RVUs on the code, every code. So like if this was a drainage of a finger abscess, our fingers ain't but so big. So if you had an abscess on your finger, like they could literally just drain it either with a needle or a small slit. So you can see that the global days on that is 10 days for recovery, 0 to 10. And then the units for pre-op is 0.1, for intra-op during the surgery is 0.8, and for post-op is 0.1. So it's not a whole lot of money involved in that for the doctors. But the greater or more involved or complex the procedure is, the greater your global days could be. Like drain if they had to drain the abscess from the tendon. Where's our tendons? It's connected to our bones, right? So the only way for them to get to our tendon or access our tendon is to do an open procedure. The drainage is probably not an open procedure. It's probably done with a needle here. But to get to our tendon, they had to make an incision. That's an open procedure. So that would warrant a greater global days or recovery period, which in turn would also warrant a higher value here for the intra-op, because it's going to be more complex than an injection because they have to cut you open. So that's kind of what this slide is illustrating here. Not going to talk about this. It's just irrelevant. Um, okay, but I do need to talk about modifiers. Not necessarily here, however. Let's talk about this one first. So modifier 24. So the purpose of a modifier, because you've heard me use the word and you're probably not really fully clear on how they should be used or even when they should be used. Every modifier has a rule. So let's go to Appendix A, because I don't think we got there last week. Appendix A is in your CPT book on page 917. 917. And there's a tab for that. All right. Page 917 is Appendix A, and Appendix A is loaded with all of the modifiers that would apply to codes in this book. So this particular slide, I wanted to have you look at this first, because if you look at some of these, they may look very similar to the ones that are on the inside cover. If they're on the inside cover, that means they're more frequently and commonly used. I would only come back here to the appendix though if you just need the full description, because like on the inside cover, if you look at 25, it just says modifier 25. It just says significant or separately identifiable E&M service, but it doesn't give you like the whole definition, right? So if you want the whole definition of the modifier, it's probably best to come to Appendix A until you get really familiar with them. Also, if you look at page 920, remember how I was telling y'all the anesthesia modifiers are in the HCPCS Level 2 book? Well, they're also here in Appendix A as well. So if you're in this book and you want to just try to minimize the amount of books you're trying to shuffle around, you can come here and your anesthesia modifiers. Some of them are here, so you will still have to go to the other book, because it doesn't have the Q modifiers. And then on page 921, those are modifiers that are approved for ambulatory surgery centers. So that would be those modifiers can be used for any surgery CPT code that will be reporting in the class or test environment. So what a modifier does is it can be used to add additional information to your CPT code. The definition of something that modifies is it changes or enhances your CPT code, or just provides additional information for the insurance companies, right? So like in this example, the modifier that they're discussing is 24. And if you look on page 917 for modifier 24, the definition is that it is used when an unrelated E&M service by the same physician or other qualified healthcare professional is reported during a postoperative period. So here's the visual. You had a total knee replacement, right? And you were using your crutches and you fell and you hurt your shoulder, which is another major joint, right? So now you go back to your orthopedic specialist, your orthopedic surgeon, and you say, hey, my knee is doing okay, but I hurt my shoulder. And so now he's turned his attention away from your knee to your shoulder. So you have an unrelated evaluation and management or an unrelated office visit by the same doctor during your post-op period. So in that event, you would report your office visit code, which it would be the 99213, and you would report the add the modifier 24. So it would look like what it looks like down on the slide for the March 15. I'm not even looking at this part. I'm just looking at the March 15 for the 99213 with the modifier 24. So again, that's if you had a total knee replacement, you injured your shoulder because you fell, you went into the doctor, the same doctor that did your surgery to address for him to examine your knee. However, he turns his attention to your shoulder. Now your shoulder has become the point of treatment, and your treatment plan for that particular visit on that date is all related to your shoulder. That would make it an unrelated office visit or evaluation and management by the same physician during your post-op period. Everybody understand that? Okay. Awesome. So modifier 25, another one, is commonly used as well with your surgery cases, only in the event that you go in for, what's this example say? The examples got to make sense for me. On the patient's arm. Okay. So you go into the family doctor for chest pain, which they would just tell you to go to the ER. That's why I got to read these examples because they don't make sense to me sometimes. Common sense. But a patient visits the family doctor for chest pain. The provider performs a complete workup of the chest pain and also removes a lesion on the patient's arm. So let's say you go in, had chest pains, and when they were checking your blood pressure, they're like, hey, what's that? What's that growing on your arm? Don't mind me, y'all, because sometimes I hear the stories and then I can envision real life scenarios. So yeah, they say, hey, what's that growing on your arm? And you say, oh, it's nothing, and then the doctor was like, well, I tell you what, let's remove it and then send it to pathology for a biopsy, right? So now you got an office visit that was intended for only chest pain, but they also performed a procedure during that office visit. So you have to have the code for the office visit, which is 99213, and add modifier 25 to the office visit, which is stating that there was a significant, separately identifiable evaluation and management service by the same doctor on the same day that a procedure or other service was also performed. And then you add the code for that other service. Need another example? Y'all need another example or y'all good? Oh, I muted everybody.
Can you do one more?
Yes. Um, one more. Okay, let me think. Okay, so I go in. Oh, here's a good example. It's not far fetched. Go into the doctor because, oh, okay. I go into the doctor because my hip is hurting, right? I've had this chronic hip pain for 3 months, you know, post operative. I had my surgery. I'm outside of my global period, right? Because I had my surgery in January. So it's well past 90 days. So they're like, all right, you're here for an office visit. We can give you something to help you with your pain. And we're going to give you a cortisone injection, right? A steroid injection. And they, sorry, they, this was real life. This happened to me the other day. So they give you a cortisone injection, which is considered a procedure. And then I bill 9921325 for the office visit, and then add a separate code for the injection, which is considered a procedure. Did I mess that up? Did I make it clearer or more confusing?
I'm slightly lost.
You have to clarify that.
Okay, who said that? That was Shaniqua.
Princess.
And
Okay.
Priscilla.
Has anybody gone to the doctor recently?
Yes, for my injection.
So you went specifically for the injection?
Yes.
And did they examine you before the injection? They did your triage. They did your
Yes. They gave me like not what's it called? Yeah, steroids that I put in my hand so I could be what's that word? Dang. So this way I can be, I will be under sedation. So they gave that to me. I was under sedation before they gave me the injection. Matter of fact, that's my second back injection.
Did they use contrast?
Yes.
Okay. All right. So we have an office visit, evaluation and management code. We'll say 99213 because they did a full triage, which would include your history and physical and um, vital signs, um,
So they
blood
did my
pressure, all of those things. Yep. And then after that, they did your injection with contrast.
right.
Which, okay. So we had two things done that day, right? We got the office visit where you saw the doctor, and then you had the injection. Two
Right.
services performed on the same day. So we got a bill for both of those services. So we have to, in some shape, form, or fashion, tell the insurance company, like, hey, she did have an office visit today, but by the way, she also had a procedure done on today. So that's why we add modifiers. We have to add modifiers to whatever service is being changed or altered. And the one that was changed or altered was the office visit because it wasn't the only one. It came first, and anything else happened after that. So office visit would always go first. And then if something else was added onto that day, you would put that 25 modifier on the office visit, and then you would bill the other codes.
Okay.
Did that help?
Yeah. So it's always the office visit first,
Mm-hmm.
and the other procedures later, allowing you to put that after.
Right.
Okay.
Did that help, Shaniqua? Hmm.
Said my name?
Yeah. Did that example help?
Yes, ma'am.
Okay. Good. All right.
Right.
And I won't go through all the modifiers, but that's basically what the rest of this presentation is. It's like 20 more slides of modifiers. So I want to talk about this last one because this one,
Chanel,
maybe I'll do, huh?
I think Ma Kathy needs you to unmute her.
Oh, I'm so sorry.
Mm.
Thank you, Princess. I think I did, my Kathy. It looks like it might be something you gotta do on your end. Hold on. It says request.
I guess I gotta do it. I didn't
Okay.
hit the request thing. Okay. I just want to go back to that other example using the code 24 and 25 because I'm just a little lost right now because can you just travel me through the EM code to get to the end, to the beginning?
Mhm.
With the book.
Okay.
Yes, with the book.
Well, here's the thing. So we're making mention of the E&M codes, but E&M coding comes later. So the real
Okay.
emphasis is, and maybe that's where the breakdown was because you were trying to figure out
Yes, where
how,
you getting up.
how to
Yes,
get to the E&M code.
exactly.
So you don't necessarily need to know how to code the E&Ms just yet, but just
Okay.
recognize for the surgery, because the focus of this section is the surgery.
I got you.
So just recognize that if there's a surgery and any E&M code, that you would need to add a modifier to the E&M code. It would
Okay.
just depend on um, if it was on the same day as it would be just the 24 would be if it occurred during your global period, right?
Mm-hmm.
So if you had surgery and the doctor saw you for something that was not related to your surgery, then you would have to add that 24 to whatever E&M code is.
Okay. Okay.
And then for the 25, if you had an office visit and they performed a surgery, minor surgery in the office, then you would have to add the 25 if that was all done on the same day.
Okay. Okay. That I guess that's what I was missing because I didn't know where you got the codes for the office visit for the for the
Oh, okay.
EM. So that's
Okay.
what I was confused. Where are you getting that code from?
From the slide, I was just using
Yeah,
examples from the slide.
I see that now, but
Yeah.
I don't see it in the book.
Okay.
Yeah.
And it's in the book, so there's a whole slew of evaluation and management codes. That chapter will likely take us 2 weeks to go through, but
Oh,
that's not until like the very, very end.
okay.
That's the
All right.
last chapter we do.
Okay. Well, I'm a visual person, so I got to see what you're talking about.
Yeah. No, I was just getting it from the slide.
Yeah. Got you. Okay. I'm good.
Okay. Cool. Modifier 57. So 57 is added on the E&M office visit on the day that your doctor decides you're going to have surgery. That indicates the start of your global surgical days. And that's all you really need to know about that one. So there are other modifiers, as I was saying earlier. Not going to go through all of them because honestly, you would use them at the discretion of your coding question. Um, so yeah, I'm going to bypass a good bit of these because they will be also further introduced as we get to certain sections that we're coding. Like if it is anesthesia, if it's radiology, you would probably use them more in those areas than in the others. So, and just clicking through some of these additional slides, you can see there's more and more modifiers. So these are all of the ones that begin on page, there's CPT book on page 921 that could be used for surgical purposes. So I'm not going to dwell on just going over those because I want to take at least the last 15 minutes right here and just kind of look at some coding examples from your textbook and help y'all out with some of those that you may have gotten stuck on. Uh, let me over here. All right, let me pull up and let's go to textbook section review for chapter 6. Let's hit the first one. Look at a couple of those. Chapter 6. Let me make sure I was in the right book. Y'all still writing your vocabulary terms and making your index cards
Oh yeah.
for your glossary words?
Yes.
Okay. Make that a norm if you're not. You writing down your practical coding notes on the note pages in your code books?
I've done some of them. Yes.
Okay. Good deal. Section review 6.1. Oh, this is good. Just a refresher. So, question number 1 on page 184 in your textbook says, what is the full description for CPT code 43622? Got to go to the code 43622. Four three six 3622. What is the full description? Who wants to tell me? Remember the indentations. Y'all want me to tell you? So the full description for CPT code 43622 is gastrectomy total with esophagoenterostomy with formation of intestinal pouch any type. And if you look at that, if you're puzzled, you have to remember that because 43622 is indented, meaning it's like spaced over 5 spaces, but it's really under the main code description for 43620, it borrows, I'll say it borrows, but remember I told y'all about the semicolon?
Mm-hmm.
So if you look at 43620, it's a gastrectomy total with esophagoenterostomy. 621 is if it was with the Roux-en-Y reconstruction, and 622 is if it was with formation of an intestinal pouch any type.
Okay.
So you always want to look at the description of the codes, especially if it's indented, if there's an indentation. So yes, the correct answer is D. Mona. Now, this next one, number 2, says which one of the CPT codes listed below would modifier 50 be appended for a bilateral procedure? So modifier 50, modifier 50 is to represent bilateral procedures. So if you have a procedure that was performed on both the left and the right side of a body part that comes in a pair, meaning 2 arms, 2 legs, 2 breasts, 2 lungs. So if it was performed on both, you would add the modifier unless laterality was mentioned in the CPT code. So for this example, you would have had to go and read the description of each of those CPT codes to see which one was related to a procedure performed on a body part that comes in twos. So we'll start with 22510. So I think I don't have the answer key in front of me, but this is a hard guess. 22510. Okay, let's go with, let me look at the next one, 36251. So this is just you having to kind of decipher 6.
Would it be 37650?
I don't know. Let me see. Anybody in agreement with her?
I'm on page 333 in the CPT code book. So we're talking about bilateral, which is 2.
What's that full description?
It says for bilateral procedure report 37650 with modifiers. So my question, would I add 50 to the 37650? Are they just asking me for the code?
You absolutely would. Yes, you absolutely would. So here's why. when I looked at, so initially, I'll tell y'all my thought process. Initially, when I looked at this, just eyeballing the codes, I knew that 22510 was a code from the musculoskeletal system. So in my mind, I was like, oh, that's got to be it because it's a bone, right? You know, it's going to be one of the bones. But then I looked at the code description, and that was for vertebral column, something with the spine. So it doesn't apply because you don't have a left and a right spine, right? So then I looked at 36251 and 252, and those were um, arterial procedures done with a catheter. And laterality was also already in those codes because one code was unilateral. It had unilateral in the description, and the other one had bilateral. So if the laterality is already built into the code, then we don't need to add a modifier to change anything because it's already there. And so when we looked at D, um, it says ligation of the femoral vein. Now, because it said the vein, we got veins all throughout our bodies, right? But then the parenthetical code confirms for you right there, the parenthetical note underneath the code, rather. It says for bilateral procedures, report 37650 with modifier 50. So you no longer need to question yourself about which one of those codes is correct because the note in parentheses just told you which one needs the 50.
Okay.
Yeah. Now it took some time to decipher that, you know, for you to research that.
Yeah.
Um, number 3 says which statement is true regarding modifier 51 in the CPT code book. So where do you think you need to go here? Modifier definitions in the CPT book. Where did I tell y'all they were? A.
Well, you can always look in the front page. I said 51, but that doesn't give me, it doesn't say multiple procedures.
Right. It doesn't give you the full definition
Right.
of the
So
modifier.
right now I gotta go and look
Yep.
back
So you
here.
should go to Appendix A.
Hmm. Okay. Which is on page 918.
And you see modifier 51.
Yeah.
Yep, 918. And so the question, which I hate these types of questions, let me
I
tell
know
you,
they tricky.
which statement is true regarding modifier 51? Okay, so A is not true. Modifier 51 cannot be replaced by using the RT and LT because that's modifier 50. We just looked at it, right?
Hmm.
B, add-on codes should always have wrong. There is no such thing as always. Anytime you see an always in code, bless you.
No, thank you.
No such thing as always. So eliminate B. C says codes exempt from modifier 51 are identified with the universal forbidden system. Symbol, sorry. Um, look at the bottom of page 918. You see the symbols down there, and you see modifier 51 with that circle with the line through it, the forbidden symbol. But let's read D just to be sure. And D says a list of modifier 51 exempt codes can be found in Appendix A of the CPT code book. Is that true? No, that's not true. Because we're currently in Appendix A, and I just flipped the pages. I do not see a list of codes. So our correct answer is what?
It's gonna be C
It's got to be C.
because of that thing at the bottom.
Mm-hmm. When in doubt, always go with C.
Yeah.
Always go with C.
Okay. Because it's got that thing, that little circle cross out.
Mm-hmm.
That means you can't use this exempt.
Okay.
Right. Number 4, the National Correct Coding Initiative files contain a correct coding modifier indicator. What does the CCM indicator 0 mean? Now, this might be a textbook question because I don't think we're going to find that in the codability. So let's skip that one. I think that one's in your reading.
Okay.
But let's look at number 5. Number 5 says, according to the parenthetical instructions, CPT code 33690, how should right and left pulmonary artery banding in a single ventricle be reported? So we need to look at what CPT code 33690. Is everybody kind of following the
690.
logic of how we're finding the answers thus far?
Yes, ma'am.
Mm-hmm.
Okay.
Yeah. 336.
33.
33. 690. Okay, so we're doing this. Yeah.
Banding of pulmonary artery says for what? Right and left pulmonary artery banding in a single. Oh gosh, I'm looking at the words and can't say them right. Single ventricle. Use 336. Do not report modifier 63. So, bending a pulmonary artery for right and left. Use 336. Oh, okay.
Would it be B?
Yes, it would.
Yes.
It would. Absolutely. Awesome. So, if y'all were able to master just the decision making process by reading the parenthetical notes, you're like more than halfway there. The next thing in conquering is making sure that you can understand what the full code description is, even when you have indentations like in number 1 where we looked at. So did anybody have a question about number 1? Do we maybe need to look at another one like that? If not, we can go to exercise 6.2 if y'all have like 15 more minutes, because this one gets a little bit, well, that's just more, I think y'all can figure that out. I want to find some where you actually have to code some examples. 6.3, skip past. Oh, it doesn't look like they're, it doesn't look like, okay. I'll tell you what, turn to page 2000, 208. 208. Gosh, that's complex. Do I want to do that one? Yeah, we'll do it. What the heck? Page 208. Documentation dissection. So this is real coder-ish right here. If you're looking on 208, there's a full operative report of a real, it looks really close to a real life coding scenario or real life surgery report, right? So up at the top you have your preoperative diagnosis and your postoperative diagnosis. Now which one of those are you going to code from? The pre or the post?
The preoperative?
Mm-mm.
Post-op. I'm sorry. Diagnosis.
Yeah. So you always want to code from the final outcome, because the reason that they're going into surgery may not be the reason. It may not be the findings of what caused them to go into surgery, if that makes sense. So they could have gone in for an operative. I'm sorry, an eyelid dermatochalasis, which is like uh, it's almost like a sty type situation. You know how you get those styes on your eye.
Mm-hmm.
So they could have gone in for that, but it could have ended up as a preoperative, but then it could have ended up postoperatively being diagnosed as cancer. So the more severe outcome would be the postoperative. Now, a lot of times they are the same, like in this example, but you still always want to code from the postoperative. Um, so just below the postoperative diagnosis, it has a procedure. Now, I think we talked about this, that you will have to read, the full procedure note, but just for starters, for your starting point, because you got to have a starting point, right? You
Mm-hmm.
start on that line where it says procedure, and that's where it's telling you what procedure was performed. Bilateral upper lid blepharoplasty. So if you remember me sharing with y'all in the CPT code book those suffixes, that would be helpful for y'all to learn, and those would be very, very extremely helpful for you to memorize. Um, Plasty means surgical repair. So that in blepharo is the eyelid. So if you were just looking at that word blepharoplasty as a medical term, it would be surgical repair of the eyelid. Now, further in that procedure description, it gives you details of upper eyelid. So there's more specifics there in the laterality. So if we go to the CPT code book, because we're going to code the surgery, so we know that our procedure is blepharoplasty. Bilateral is an adjective. Upper eyelid, more detail, just describing the location. But our main term for that procedure is blepharoplasty. So CPT index. Blepharoplasty. And all right, so it gives us codes, or code range, a range of codes from 15820 through 15823. So we have to go back to research those codes, read the description to determine which one is going to be the best fit for what was performed in this surgery. So we got 15820, 21, 22, so it's that whole range of codes. So let's turn to 158.
Eight.
0 is lower eyelid. If y'all have gotten there, it's on page 118 in the CPT book. So if you look at 15820, that is the blepharoplasty lower eyelid. So that's not our code, because we know our procedure was performed on the upper. If you look at 821, it is an indentation of 820, so that's not our code. 15822 is blepharoplasty upper eyelid, and then there's also an option for 15823, right?
Mm-hmm.
So now this is where you make the decision. Okay, since I got two possible code options, I need to read some more. Now, that's when you go. So I always start at that top level, that top part of the note where it says is giving you that procedure description. And then if you need to research more, because we very well could have found our answer without having to read the body of the note, and that's why I start up at the top.
Mm-hmm.
But now that we have the option between 15822 and 15823, we need to read more to decide which is going to be the best fit. So I'm just going to point y'all directly to the area in the book, which your page should look just like my page. So is your you see the sentence in the 4th paragraph where it starts out with the bilateral upper eyelids were injected. So that's really where they're getting into the meat of the procedure.
Yeah.
See the sentence where it says excessive skin of the right upper eyelid was excised with Westcott scissors.
Mm-hmm.
Yes.
That helps you make your final decision on which code to pick. So look back at 15822 and 15823. And so now which code do you think we need to use?
15822.
Look at 23 again.
Okay. Okay. Let me go back and see if I can find that.
See back in the
Oh, the excessive. Oh,
What five eight
yes.
your excessive skin was
Yes,
before
and 3.
upper
Yes.
eyelid in the same fashion.
Yep.
Yes. Eyelid skin in excess. Yes.
Mm-hmm.
So it's 5823. I had to go back and find excess.
And
Okay.
notice they did it on the left and on the right.
Left and the right.
So
Okay.
that is bilateral, right?
Yes, bilateral.
Okay.
At Mar 550.
So I don't like the way they gave the answer on this one because the CPT book exam is going to want you to use 15823 with modifier 50.
Yeah. Wonder why they gave us all that other stuff.
Because sometimes hospitals have their own preference of how they want things billed because there are modifiers specifically for the eyelids, but because we are using CPC, AAPC's specific code set and guidelines, they really go by CMS, and CMS, being the overseer of all things billing and how things should be billed and coded, prefers modifier 50.
Okay.
So 15823 50 would be the appropriate answer. Any questions on how we got that answer? As far as identifying the keywords, reading through the procedure note, going to the index, looking for blepharoplasty, and then going back to the CPT book to read through your code descriptions to ultimately find your answer.
Yeah, that was good. That was helpful.
Good.
That was good.
Let's look at this other one. So this other example is it's a good example because it looks busy. but your end result is still going to be one code. So notice for case 2 on page 209, sorry, we have a preoperative diagnosis of right temporal metastatic tumor. We have a postoperative diagnosis that's different. So that's why, again, we always quote from the postoperative, because it has a right temporal metastatic tumor and also metastatic lung adenocarcinoma. So that means the patient had cancer that spread to the lungs and to the temporal lobe, or the temporal lobe, sorry. So the procedures that are performed is right temporal craniotomy, excision of a metastatic tumor, and insertion of an ICP monitor. We are going to start with, in our search, craniotomy. So think about this for a sec, and for as far as anatomy is concerned. Where's our cranium?
It's in the head.
Mm-hmm. Inside the head.
Yeah.
Yeah, this the head. So, in order for them to get there, we had to do what? Go inside, make an incision to take out the tumor that is located in the temporal area, also an excision. So that kind of helps your logic in the end, because you got to go through bone in order to get there, right?
Mm-hmm.
So otomy is, the suffix otomy is cutting into. They had to cut into this bone to get there. So, okay. So we'll start with craniotomy in the index of the CPT book. So this is the fun part. You know, a lot of people, they don't care for the diagnosis coding part, but this is like really the part that gets me the most excited. Because once you get a good rhythm and concept going, you'll be unstoppable. And everything else will just kind of, like, as the weeks go, whatever is not clear to you is going to start getting clearer. Yeah. Okay, so excision of tumor.
Okay.
So when we go to crate, oh Lord, craniotomy.
1074.
Yes.
Okay.
So we see a lot of detail there, right?
Yeah.
A bunch of them.
So this is where I would again go back to, so the more options you have, the more information you're going to need to know in order to pick the right code, right? So this is where I would kind of go back to reading the op note again, the op report, and just kind of highlight key things. So I'm going to guide y'all. So go to that second paragraph on page 209 in that under case 2. Um,
That starts with this 64-year-old gentleman.
the next one, the patient was brought into.
Oh, okay.
So patient brought into the operating room in the supine position on the operating table after general endotracheal anesthesia was induced. The head was secured in the Mayfield brace with pins. The right temporal region was shaved, prepped, and draped. The incision was performed to the right of the temporal region. Self-retaining retractors were placed. Okay, a burr hole was then made and the bone was dissected, resulting in a 4 centimeter circumferential opening. So that's important to know, which we know they did a craniotomy and we knew that they had to take the bone out in order to get to. So that is going to help us answer the question, okay, well, is there a bone flap if you took the bone out? So go down about, well, no, let's keep reading. Dissection was continued through to the temporal lobe where a single encapsulated lesion was present. The tumor was removed intact with minimal brain dissection. The tumor was approximately 1 by 1.4 centimeters. That would matter for pathology, but not for right now. But just so you know, hemostasis was obtained with a bipolar cautery, which hemostasis just means that the patient was stable and they were able to stop any bleeding. The wound was irrigated with backcitration, 1,000 milligrams, and interrupted sutures. An ICP monitor was placed, and the bone flap was returned and secured with dural closure clips. So, when we go back to the index to craniotomy, at least now we know that it was with a bone flap, right? So that's our starting point to identify what codes we need to research and read the description for. Still a lot of codes, but we've narrowed down to 61510 up to possibly 61567. Everybody good so far?
Uh-huh.
Okay. So let's go to 61510 and just kind of start breaking it down and seeing again which code is going to be the best fit. It may feel like to you that it's taking me forever. It's not a speed game. Right now, it's just all about taking the time to learn the concept. So don't worry if it takes you, an hour to do 2 questions or 3 questions. That's totally normal. The more you do it, the um, more speed you'll obtain behind navigating through the book. But remember, you're still learning the book, so don't beat yourself up. So 61510, we'll start there, is 61510. Craniectomy, trephination, bone flap craniotomies, otomy for excision of the brain tumor, supra, intorial. What is it? Trephination of the It does not say anything. Oh, okay. All right. So if you turn to page 210, so this is helping us out here because I don't know everything, right? So I had to look up what trephination meant, and then I noticed that it was on page 210. Do y'all have that on your page 210? We have the same book, so I should. In the textbook, 210.
Oh,
Because it's kind of giving you a guide of how to find the answer.
okay.
Yes, Mylene. All right, so it's how to utilize the alphabetic index. So we've already done that part. Rationale. Code 61510 states trephination in the code description, which trephination means cutting a circular shaped portion out of a part, in this case the skull. Do not let the terms confuse you during your code verification. You'll have to look up some words in a medical dictionary until you become familiar with the codes and terminology. Or Yes, I am. Sorry. No, ma'am. Where's your pants? Please go put some. Come on.
Hi, Ashley's
Hi.
Simmons.
I know. Hi, Marlene Simmons. She wants a hug. You want to tell my class hi?
Hi.
Wait, they can't see you. Hold on. And they're trying to figure out something very, very difficult.
Hi, Marlene.
Hi, Marlene. How are ya?
Eileen Simmons.
Oh.
Marlene Simmons. Hi. How you doing?
She's like, get it right, guys. Get it right.
You ready for bed? You ready for bed? She said no.
Are you ready for your gummy? Yeah. Yeah. Okay, bye.
Oh, see.
Okie dokie. Yep, she might be getting a double. Okay. Where were we? Yeah. Okay to use, your Google, your medical dictionary, which is why I recommend it. And then let's see.
Get myself together.
This one is a little bit complex anyway, but I will, reading this helps. It says you may have had difficulty understanding the procedures. Professional coders must use various methods, such as the Internet Dictionary or your anatomy book, to research the procedures, products, and diseases to be able to locate and assign a code to the documentation. So ultimately, the correct answer in this example is going to be 61510. It is 61510 because it describes the procedure as craniectomy, which ectomy, even though in the code description, in our question it said craniotomy, we know that they had to cut into that bone in order to remove it, right? So that then makes it an ectomy because the suffix ectomy means removal. Craniectomy, trephination, removing the bone in the circular format. Bone flap was done for excision of a brain tumor. We knew that that's what that was. Supratentorial, except meningioma. So we know that this was for, remember what the diagnosis
Okay.
was.
Yeah.
A metastatic. So it was not a meningioma.
Mm-hmm.
The operative report also stated an intracranial pressure monitoring catheter, the ICP, was placed. Code 61210 for the burr holes for implanting ventricular catheter reservoir, EEG, pressure monitoring device, and or other cerebral monitoring device is not reported because it is bundled. So they did other procedures besides taking out that bone and removing that tumor. We saw that they also did the burr holes, which would typically be billed as an additional procedure, but there is a note beside 6120 that says it can only be reported or include separate procedures. Sorry, 61210 is included in the 61510. You would see that when you go to your parenthetical notes. So all in all, for this particular example, we would report 61510, and the answer key says with modifier 80. So I'm looking at modifier 80, and 80 is, I know it, but I just want to make sure I'm,
It's
okay.
the assistant surgeon.
80 is with an assistant surgeon. So for us to be able to identify that, It should be in the note.
It's on page 209 at the bottom.
Dr. Joe was present for the entire case and assisted with the approach, definitive surgery, wound closure, and dressing application. Oh, and it's up at the top. That's what I was looking for. It's usually up at the top too. Underneath the procedure, it says that there was an assistant, Dr. Joe Smith, and that modifier 80 should be added. So in a real life coding scenario, actually the doctors do like to kind of put on their notes for assistance, or sometimes a surgery can be so complex, or the patient can have underlying conditions where they'll have two surgeons, like two active surgeons, not as assistants, but both of them performing separate parts of the procedure. So they both will get to bill for full service and not as an assistant. But those are unusual circumstances. So that example required a little bit more detailed research, a little bit more thinking on our parts. But again, glad I was able to walk through both of those examples with y'all, so you can kind of understand a little bit what type of thought process you need to be in when doing these. Hope that was helpful. And from this point on, we'll be hitting the ground running. So I owe y'all a few things. I need to grade chapters. I need to grade some things. I need to go back and grade your practical applications. I need to send y'all an updated syllabus, because we have had, some weeks, the weeks I was sick, and then we spent extra time on a couple of things. So I'll send an updated syllabus just so y'all will have dates and kind of like a projected timeline of what's going to happen when. And is there anything else that you all need from me to make this the best experience that it could possibly be for y'all?
Yeah.
Lectures, I'll get those out to y'all timely.
I still like the lectures.
Okay. Yes, my Kathy. If one person feels that way, then y'all all probably feel the same. So I will make it my point to make sure, and I do apologize for that, but I will get the lectures out to y'all in a more timely fashion. Ideally, I would like to make that a less than 24-hour turnaround. So I will work to get that done no later than 24 hours. I'll say realistically, because I don't want to say by noon or lunchtime and then that doesn't happen, and then I would have lied. So within 24 hours. Also with the PowerPoint presentation and any other notes that I think would be helpful to y'all from this point. So please accept my deepest apology on not getting that information to y'all in the previous week's timely, but just know that it will not happen again.
You all right?
It's all good.
You it's all good.
Thank you, thank you.
It's all good. We love you.
I love you too. Is there anything else that I can do for you all before we cut off for tonight?
Yep. Hopefully, I'll like 101, but I'll let you